Good morning. Thank you for having me. My name is Luke White. I'm a practicing psychiatrist at Kaiser Permanente in Redwood City and San Mateo. My boss is over there, so a lot of cheering, please. As you heard, I'm board certified in psychosomatic medicine, which means I provide care in any setting where physical well-being and mental well-being may be intertwined. For a lot of my career, that meant doing consultations for patients who are acutely medically ill, admitted to a hospital. More recently, I've been working in what might be called an embedded role in primary care. So I'm a psychiatrist, but instead of working in the Department of Psychiatry, I work alongside our primary care doctors. And my primary role is to improve how mental health care is provided in that setting. So rather than patients always needing to come to psychiatry to get optimal mental health care, we're trying to do that within the primary care setting. So today I want to talk to you about some changes in the way mental health care is being delivered that promise to reach significantly more people with evidence-based, effective care in a way that's both scalable and sustainable. I'm going to tell you about how these changes are specifically improving our ability to treat depression, which is a really common mental health problem with far-reaching consequences for the lives of individuals and for society as a whole. So by treating mental health care as an essential part of primary care, we can have a much greater impact on our patients and on society as a whole. I'll give a warning that my talk will touch on some difficult subjects, including severe depression and suicide. So when I started my career in medicine, I was drawn to psychiatry as a kind of final frontier in our understanding of our biology. There's nothing more complex than the human mind, in my view. And so nothing's more mysterious than, how does it generate thoughts, emotions, who we are as people? Psychiatry, I thought, presented this opportunity to use cutting-edge science to heal people from illnesses that really affect what makes them themselves, what affects the narrative of their lives. I hope that I would be joining psychiatry at a time of explosive growth of understanding of how the mind works through neuroscience and other developments, and that those advances would provide exciting new treatments. So I can say that in many ways, in the years I've been practicing, a complete understanding of the biology of mental illness is still many years away. And the revolution of new pharmacologic treatments that I expected to be coming out in the midst of my career may be further away still. But what I think really has advanced during my career, and what I've come to have as the focus of my career, is that we can improve our ability to deliver care in ways that are effective if we focus on the scientific evidence, and if we use the tools to treat depression that we have now and provide them in an optimal way. So I'm going to talk a lot today about evidence-based care. So what does this mean? This means treatments that rely on treatments that have been rigorously tested with the best available scientific methods that are demonstrated to be effective, tolerable, and safe. The best evidence comes from well-designed studies. So as much as possible, when we're looking at a treatment and trying to decide, is this the right treatment for our patients, we want to make sure that we're removing the bias of the people conducting the study, removing the bias of the people in the study. It's human nature to want to put more credence into anything that sort of confirms what we already believe. That's our nature. Really well-designed studies take that out of the equation as much as possible. We do this, potentially by randomizing patients to getting either an active treatment or placebo, or comparing our new treatment to treatment as usual as much as possible. And by doing that, we can minimize this tendency to move towards treatments that seem exciting, that seem compelling. Maybe they have enthusiastic champions, but in actuality, they may not help as many people as we'd like. So I'm going to talk today about, what are the evidence-based treatments for depression that are available now? What are the strategies we can implement to identify patients with depression, to keep them engaged in treatment? When we do that, we really have better outcomes. So really what I'm going to argue today is we already have treatments that work. We just aren't making them work for our patients as well as they could. I'll hope to convince you that effective, safe treatments are already here. To do this, we need to refocus our understanding of mental health as a specialized area of treatment and rather see it as essential to primary care. So integrating and enhancing the delivery of mental health care in a primary care setting leads to much better outcomes for treatment of depression. To help illustrate how this approach differs from treatment as usual, first I'm going to tell you a story, a made-up story, but a typical story from the perspective of a patient who's not doing well and is going through that experience with what we might call treatment as usual. So James is our patient. He's a 28-year-old teacher. He's been feeling down for the past few weeks. Unlike his usual enthusiastic self, he's been experiencing a sadness that doesn't seem tied to any particular event. He still goes to work, he maintains his social life, but everything feels more challenging. He's less interested in his hobbies, he's not, engaging in social gatherings, and he's noticing a subtle yet persistent fatigue that's setting in that wasn't there before. So he manages to get through his daily routine, but he's more irritable. He finds himself procrastinating, feeling guilty about it. Eventually, he's losing weight. His sleep is off. He's waking up early than he needs to, and he can't get back to sleep. So he goes to see his primary care doctor. It's a routine visit. He's actually there to check in on his asthma, but he dutifully answers a questionnaire, which reveals some of these symptoms. He's surprised that his doctor says his symptoms warrant a trial of an antidepressant medication, even though there's little time in the appointment left to discuss it. Most visits are 15 minutes, and this can come up and then has to be dealt with at the same time as whatever else brought the patient in. So when the patient seems uncertain, his doctor suggests if he doesn't want to try medication, he could try to find a therapist, but he might have to pay out of pocket. It might be difficult to find somebody who's accepting patients with his insurance. His primary care doctor doesn't think his symptoms are quite severe enough to warrant a referral to a psychiatrist. And even if she made one, he's potentially looking at weeks to months of waiting to see somebody. So he hesitates. He does some research online. But in the end, he doesn't take the medication. 2 months go by, and then he does see a psychiatrist. By then, his symptoms have worsened. At the end of his visit, he feels much better understanding of what the drug is that's been recommended, but it's the same drug that the primary care doctor recommended. When he takes it, he starts to feel better. Despite feeling better, he's unsure if he should continue on it because he ends up having a side effect. He can't get in touch with his psychiatrist. When he sees them after 6 weeks, he's come off the medication, but they find another one that works. In the end, he feels better. He's on a medication that works, but it's been 3 months until he found that medication, and he's not quite all the way better. He doesn't feel entirely like himself. He still has difficulty sleeping. His energy levels are still pretty low. So cases like this are unfortunately common. Patients may be unsure what to call a mental health problem when they're experiencing it. Is it a mental health problem? Do I need treatment? When we speak about clinical depression, we're not referring to the usual sadness that follows a difficult life event. Major depressive disorder is defined by the Diagnostic and Statistical Manual, which is kind of the Bible of psychiatry and psychology. It's how we define mental health problems. It's defined as having persistent sadness or low mood, or an inability to enjoy things that lasts at least 2 weeks. And then over the same time period, people can have appetite change, sleep disturbance, lack of energy, feelings of worthlessness or guilt, poor concentration, changes in their motor activity. So people either feel really slowed down or maybe they feel agitated and restless. And they may have excessive thoughts of death or even thoughts of suicide. We don't call it major depressive disorder if it's better explained by something like grief or another mental illness. But this is what we're talking about sort of in clinical terms. So, we use these criteria to define our research, guide our clinical practice. But I think it's always useful, to discuss the experience of depression in more human terms. Kay Redfield Johnson wrote a memoir of living with major depressive disorder called An Unquiet Mind, which I think is one of the best written books about an experience of mental illness. She writes, others imply that they know what it is like to be depressed because they have gone through a divorce, lost a job, or broken up with someone. But these experiences carry with them feelings. Depression instead is flat, hollow, and unendurable. It is also tiresome. People cannot abide being around you when you are depressed. They might think that they ought to, and they might even try. But you know, and they know, that you are tedious beyond belief. You are irritable and paranoid and humorless and lifeless and critical and demanding, and no reassurance is ever enough. You're frightened, and you're frightening, and you're not at all like yourself, but will be soon, but you know you won't. So I think sometimes an artist's words can capture what a clinical manual never could. I don't think this describes everyone's experience with depression perfectly, but I think it drives home the fact that this is a really serious illness and one that is worthy of attention and care. So depression is common. It has a significant impact on the lives of individuals and society as a whole. The National Institute of Mental Health did a survey in 2021 and estimated that 21 million adults in the United States had experienced at least one major depressive episode, representing 8.3% of the population. Prevalence is slightly higher in women than in men, highest in individuals aged 18 to 25. This number of episodes of depression represents over 800 per practicing psychiatrist in the United States. So for me, this really drives home the point that primary care physicians are bound to take care of this. And actually, primary care doctors excuse me, write more prescriptions for antidepressants as a whole than do psychiatrists. So depression is also a major cause of functional impairment, and it represents a really important public health concern. Even with mild depression, patients are twice as likely to be unemployed. They're more likely to require medical care, less likely to engage in health-promoting activities like a good diet, regular exercise, socializing, and they're less likely to adhere to recommended care for other physical illnesses. So as a result, patients with untreated depression are much more likely to have other serious medical problems like heart attack, stroke, or experience severe complications of chronic illnesses like diabetes. So patients with depression are 11 times more likely to die by suicide than patients without depression. So when we look at the clinical costs and the estimated costs of what all of this impacts on society, the NIMH puts it at $83 billion a year lost towards treating depression and what effects it has on our society. Despite this problem, and despite knowing what depression is, and as I'll argue, knowing how to treat it, more than half of patients with depression never receive any treatment at all. Only an estimated 1/3 receive adequate evidence-based care. The barriers include poor access to care, the stigma of seeking mental health care, lack of screening for mental health conditions, and inadequate systems to make sure that once we start patients in treatment, we continue it until they're all the way better, or in full remission, as we would say. Because of its impact on health and quality of life, again, I would argue mental health care is primary care. And because of this, efforts to integrate mental health care into primary care have been underway and have been studied extensively in recent decades. The collaborative care model differs from traditional delivery of mental health care, and it's been shown to significantly improve outcomes for depression and other disorders, though I'll focus on depression today. So treatment as usual would separate mental health care into one silo over here, and primary care can refer into that, but it's somewhat of a black box. Patients go there, they get their treatment. There may not be a lot of talking. There may not be a lot of actual communication between providers. And patients are sort of left to their own devices to follow up. They are now responsible for twice as many appointments. When you're depressed, this is a difficult thing to do. And patients, usually need to reach a pretty high threshold. As I mentioned before, psychiatrists and other mental health care professionals are a limited resource. We may not see primary care doctors referring unless they think someone is especially ill. So communication can improve the patient care experience, but I'm going to talk about how integrating care can change how care is delivered from start to finish, and how it can be, what principles drive the better outcomes that I'll discuss. So collaborative care is distinct from treatment as usual because of 5 key principles. So these are patient-centered team care, population-based care, measurement-based treatment to target, evidence-based care, and accountable care. So I'll describe how each of these can influence care delivery and the experience patients have, being patients in these systems. And then I'll discuss what does the research say, how effective are these interventions. All right, so patient-centered care. This refers to care that is shared by multiple providers across primary care and specialty mental health care, and it encourages treatment plans that incorporate a patient's individualized goals. So patients get their physical and mental health care in one location. This increases patient comfort and acceptance of treatment, it reduces stigma, and it increases the engagement of many patient populations that historically have resisted referral to specialty mental health care. And this can include racial minorities and elderly patients. So care teams can be what we might call co-located, collaborative, or integrated. So just having a mental health care provider in the same space can have a big impact. Patients are much more likely to be accepting of mental health care treatment when it's delivered in that way. But what we really strive for is more collaboration and integration. So this means that members of both specialties are going to be involved in the patient care every step of the way. So we create a treatment plan that may continue to have a primary care doctor writing prescriptions, but now there's a therapist that can provide education about depression, can conduct psychotherapy visits if that's indicated. There may be case managers following up with patients to provide regular touch points, and then a psychiatrist available for consultation about medication management, or even helping decide when a patient might not be doing well enough in this setting. They might need a higher level of care. So patients should experience a warm handoff. They should be rapidly connected to providers so that they can learn about their treatment options and begin their care. So patients are given a roadmap of what to expect and should ideally begin treatment immediately, if not within days, if not weeks. So population-based care. This refers to the practice of a team monitoring and tracking the progress of patients with depression. Really, the goal here is nobody falls through the cracks. Rather than leaving the burden on patients to follow the doctor's instructions, reach out when something's going wrong proactively, the team will proactively reach out to assess patients, encourage adherence to treatment, and modify treatment plans as indicated. So patients are much more likely to start and continue evidence-based treatment when we do this. When we encourage them, when we help them make adjustments if things aren't going well. In collaborative care, a psychiatrist may often proactively consult on patients that aren't doing well. So this is one of the things that I do. Every week, we have a case manager who identifies patients who aren't progressing as rapidly as we think. They haven't met their target yet. They're not doing as well as we might like. And I'll look through their chart, and I get to be sort of a detective and think, is there something we missed here? Is there another treatment option that might be the most logical next step? Is there something we should be offering that we haven't thought of yet? So I'm doing that, without the patient or even the doctor doing much of anything. Really, this allows us to be proactive and identify and fix problems before things get worse. So measurement-based care. This refers to the practice of using validated tools to regularly assess patient progress and ensure patient treatment advances until patients have really achieved a meaningful improvement. So rather than just, the patient told me they're getting better, I have a general sense that they're getting better, we want to use as objective a measure as we can. So symptom questionnaires can be performed much more frequently than patient visits because patients can complete them on their own, or with assistance of staff members, in a wide variety of roles. So patient care technicians, caseworkers, psychologists, nurses, they can all share that burden of having multiple touch points with the patient and making sure we're assessing them along the way. Now, some of us might not particularly like symptom questionnaires. They might seem impersonal. They might seem like, okay, that's not a great substitute for an in-person, face-to-face visit. But what they do, in providing these additional touch points, it's not a replacement. It's in addition to what we're able to do. And these tools are validated against what a clinician might find. So they give these questionnaires to many patients. They have an expert interview them alongside it, and then they compare the results. And what we find is, while these may not be a therapeutic intervention, they're pretty good at figuring out, okay, how's the patient doing now? How well would an expert say they're doing versus a few questions? So they really can have an important role in terms of our knowledge of how our patients are doing over time. But beyond that, they're in addition to giving us accurate information, it can be more timely. So we can figure out when patients aren't doing well much sooner. And we can also avoid the trap of abandoning care prematurely. Maybe we think, oh, the patient looks better. My own bias as a clinician is this might be as good as this patient can do. If we're using these questionnaires properly, we're going to set goals for them, and we're not going to stop until we find something to get them across that threshold. All right, so I've discussed the meaning of evidence-based care, but I want to highlight how evidence-based care treatments can be tailored to a primary care setting and how we can make available treatments effective and available to everybody, really. So medication treatments are often prescribed by primary care physicians, but in the collaborative care model, they're going to have access to an embedded psychiatrist like myself, so I can guide them towards effective use of these medications. And hopefully we can improve for a specific patient, how safe is this medicine for a patient with a complicating illness? How tolerable is it? Can we improve the likelihood that they're going to take it by picking the right medicine that's going to feel right for them? All too often I hear, well, I use that. Why did you pick that antidepressant? Well, I'm comfortable with it. I know how to use it safely, right? It may not be the perfect one for the patient, but a clinician is going to do what they know. In collaborative care, patients will also have access to evidence-based psychotherapy, which can be delivered by staff who are based in primary care rather than having to go seek out treatment on their own or suffer through wait times to a specialty clinic. So the way we can offer universal access to therapy is to make sure that it's targeted, it's time-limited, and it's forms of psychotherapy that have a solid base of evidence for treating the condition. So these treatments, that have shown benefit in primary care settings are cognitive behavioral therapy, problem-solving therapy, and behavioral activation. And I'm going to talk a little bit about each one of these because I think it can give a sense of how they work and why they may work particularly well in a primary care setting. So in cognitive behavioral therapy, patients are encouraged to systematically identify and challenge ways that their thinking has been distorted by their illness. In depression, patients often have a very negative view of themselves, negative view of those around them, negative view of how things might develop in the future. So patients are invited to put these thoughts to the test and consider as objectively as they can, with the guidance of a therapist, what's the evidence for the core belief underlying this mode of thinking. Over time, this can actually affect their core beliefs and can change their patterns of thinking and helps to improve their mood. This is the theory anyway. They're also encouraged to identify patterns of behavior that seem to worsen how they feel, seem to worsen their mood, or seem to improve their mood, and then come up with plans to modify them accordingly, with a therapist to keep them honest about it. So CBT has the best evidence, really, of any form of psychotherapy for the treatment of depression. Typically, it's, in research studies, it's conducted with weekly sessions for about 8 to 10 weeks. But in a primary care setting, evidence suggests that even 4 to 6 sessions may be effective for many patients. Behavioral activation therapy is another form of therapy that can be effectively delivered in a collaborative care environment. So it involves monitoring trends in daily activities and moods, scheduling activities expected to improve someone's mood or their mental health, and gradually increasing exposure to healthy activities. So it's really having a cheerleader who can help you identify what are the things you already do well, or what are the things that have historically kept you well and getting you back on track. And then problem-solving therapy is a form of CBT, or cognitive behavioral therapy, that focuses on identifying present problems that a patient faces. Then we set realistic goals, we generate solutions, we review progress, and in this way build coping skills. And this can be especially helpful for patients who may be wary of sort of psychotherapy potentially feeling invasive. It's got a very practical nature. We're not doing exploratory work here. We're focusing on what a patient needs to be well. It's also been shown to be especially helpful for patients with chronic medical problems or for elderly patients because it can really help to adapt to the changes that come in one's life with advancing age or with illness. And often it's as simple as connecting patients to local resources that can improve their social engagement and again help with coping skills. So both problem-solving therapy and behavioral activation therapy have been shown to be effective elements of treatment in primary care settings. And one thing that was really exciting for me to read was a study that showed that even if these were delivered by a staff without a formal background in psychotherapy, it could be helpful. And so it opens up possibilities of how can we scale this up? How can we offer this to everybody, knowing that it is effective? So some common themes of these more modern evidence-based treatments is that they're present-focused, they're time-limited, they're practical. So traditional models of psychotherapy may provide a great benefit to people in their daily lives, but the research is clear that for patients meeting criteria for an illness like major depressive disorder, actually the modern therapies are more effective. Since the treatment models are time-limited, if we widely adopt them, we can put a big dent in those month-long wait times that some patients have to see a psychotherapist. And then briefly regarding medication, I would add that antidepressant medications clearly help patients improve from depression more rapidly, improve their quality of life. It's clear that they reduce suicide attempts. But even in a treatment as usual modeled clinic, people have good results. But there are barriers to benefiting from antidepressants. A lot of doctors don't have enough time to adequately inform their patients of how to take them properly. They may not have time to really talk about the risks and benefits or tailor the treatment to the individual, so they may not trust that. They may not want to take it in that situation. So they don't feel that they have a shared decision. And so a lot of the time, the ineffectiveness we see with sort of what we would call intention to treat research, where we give patients the medication and we just sort of see what happens. It's as naturalistic as possible. We're trying to see what happens in the real world when we give these medications. A lot of the gap in terms of the effectiveness we want and the effectiveness we're seeing is just that patients aren't actually taking them as intended because they don't like them, or something really important and that was negative to their experience got in the way. So the final principle of collaborative care is accountability. So with a team approach, primary care and mental health care clinicians share the responsibility for mental health care outcomes. So patients don't feel like they're sort of being referred to that black box. Primary care physicians are involved. They can improve their competency in treating mental health problems by learning in collaboration. So one of the things I do is, regularly give talks to my primary care physician colleagues, try to help them to troubleshoot some of the problems, how to, optimize their treatment decisions, even before they call me, which is great. So the patient experiences a unified team, and when they're well again, they continue care in the same location, not feeling like they've lost the support of their mental health team. They're already in the same place. And for patients in a fee-for-service model, there's also been a lot of headway in terms of getting reimbursed for what's essentially preventive care, proactively reaching out to patients. That was a difficult thing to get paid for in the past. One of the things I like about working at Kaiser, which is a subscription-based model, is we can prioritize anything we think will improve outcomes. We get the same amount of money from patients regardless of how many times we see them, regardless of a lot of factors. But if we think that something will be cost-effective and will help people get well, we can do it. I really enjoy being able to focus more on outcomes and not so much on the economics. Okay, so I've said, in order to deliver better care for depression, we really should be relying on the evidence. And then I've laid out sort of what is this different attitude and methodology, this different model of care look like. So now I'd like to talk about what does the evidence say about primary care, or collaborative care. In short, integrating mental health care into primary care in the ways I've discussed today leads to much better results for depression. In a wide variety of treatment settings and for a wide variety of patient subgroups, we can see this replicated. So an analysis of over 90 studies of collaborative care treatment involving a total of over 25,000 patients, collaborative care was significantly more effective than traditional care and improved depression outcomes both at 6 months, so sort of that initial phase, but also 5 years in. We see that patients are much more likely to be doing well, much more likely to have had less time depressed. Patients are more likely to receive evidence-based treatment. They're more than 3 times likely to have a positive response to treatment. And patients taking antidepressant medication are 50% more likely to take them properly as directed and to continue on recommended treatment, even if a medication change is required. So that's all great. That's what I'm looking for. But patients are very happy too. Patients report a greater satisfaction with their treatment and improved overall quality of life. And as a clinician, these are really the measures of success that matter to me most. So, importantly, these positive results are true when we look across a wide range of settings and patients. But when we look specifically at patient subgroups or treatment care locations that might be challenging, we see really promising results as well. So for patient groups that tend not to seek care for depression or who may not be adequately screened or offered treatment for depression, we see equally good results. So elderly patients are much less likely to seek or accept treatment for depression than younger adults, but they're much more likely to adhere to treatment for depression when it's given in a collaborative care setting. So the research suggests elderly folks really like to get their treatment in this setting and are much more likely to be on board. Patients from ethnic and racial minorities are statistically less likely to even be asked about depression or screened for depression in a treatment-as-usual setting when compared to their white counterparts. But when we use screening tools, as a treatment standard, when we use a registry to keep track of patients, we see that this can really close that gap. So when we look closely at the data of what's driving the improved outcomes for patients in collaborative care, why do patients as a whole do better? A lot of it is that the patient groups we might think of as the most vulnerable, the ones who are being overlooked or for whom our treatment setting and treatment as usual is just not really the right thing. Those patients are responding the most. They're improving over traditional care the most. Okay. And collaborative care has also been shown to improve outcomes for patients with chronic medical conditions. Oops. Patients are much more likely to adhere to their treatment for chronic medical conditions. They're much more likely to engage in health-promoting activities like healthy diet, exercise, when they're treated for depression in this mode as opposed to treatment as usual. And collaborative care has been shown to be effective even when most of the mental health care practitioners are in a virtual setting. So there's some interesting studies that found that even when we try to integrate this or just sort of add it on in a modular fashion to a primary care setting, say in a rural or underserved area, we can have equally good outcomes. So to conclude, depression is a common mental health problem that leads to a great deal of suffering. But I don't think we need a revolution in the treatments available to treat it better. We have good evidence-based treatments now. What we need are better methods of bringing those treatments to people in need. That involves better methods of identifying patients in need, better methods of keeping them engaged in treatment. And I think that delivering care in an environment where everybody goes, can reduce stigma, it can improve the likelihood that patients will be accepting of what's recommended and can keep them on track. So this is a way to really allow for cost-effective care to reach all of those in need. So thank you for your attention. And with the remaining time, I'd love to answer any questions. Yes.
As you were describing the depressed person, I kept thinking of people I know, right? And is it safe to identify them as pessimists or just optimists?
Well, I think while a person is depressed, they are pessimistic. I mean, I think that's part of the illness. I think it tends to be something that is that is visited upon people as opposed to they're just a pessimistic person. I mean, there are people, I think, who suffer with more chronic depression. There's an illness called dysthymia, which is sort of potentially a lifelong low-grade depression. So that does exist. But usually when we're talking about depression, we're talking about a discrete episode in someone's life where they are not themselves and their thinking is distorted. They don't sound like themselves. And so their worldview, their view, and especially their view of themselves tends to be very pessimistic. Yes?
So I would like to know if you can address a subcategory of depression, which is postpartum depression.
Sure.
It can be very disabling. My question to you is, you refer to primary care a lot, which is collaborative.
Yeah.
Where does the OB fit into that model, and how often are they utilizing it?
So that's a fantastic question. I think postpartum depression is very common, and I think also an under-recognized and under-treated condition. And I think that's a whole talk, to be honest, to answer your question. But OBs also take on a lot of what we may think of as primary care. They're prescribing antidepressants. I think even in treatment as usual, a lot of OBs are taking on that role. But I think they, as much as primary care doctors, if not more, are very eager to have the support of a mental health care team. Some of the most difficult consults I've gotten in my career are in the postpartum period. There are now two, very vulnerable individuals when we're treating a new mom who's depressed. There are a lot of rates of complications for new moms. And I think we're coming to learn also there may even be a different biology. So there are some synthetic hormone analogs that can be given to patients with postpartum depression that have much better outcomes than antidepressants. But I think what you're asking about is sort of how does that fit into this model, right? And I think of OBGYN, women's mental health as primary care as well. And so I think that this model belongs in that setting as well. Yes?
Why is it that in the insurance world, including Kaiser, we have our medical benefits and our mental health benefits? And is that model an obstacle to your idea of collaborative care?
Why is it? I think there's a lot of arguments to be made about why is it. I think that I think it comes from a legacy of thinking of mental health illnesses as not based in biology or not the purview of a medical doctor. or just somehow qualitatively different, and I would argue, maybe not deserving quite the same level of attention or care or investment. So I think it comes from that. I think that that's changing a lot. And there are mental health care parity laws, so it's not supposed to be separate. I would plug for Kaiser that it's not really a separate benefit at all. You're a Kaiser member, you have access to all of our services. But I think it's a legacy of how people thought of mental health care as very different, and I'm very fortunate to be working in a time when I think that's changing a lot.
Around for a bit longer for people to ask you more questions.
Sure.
Thank you so much. We want to thank Dr. White for coming and providing this vital information for us. We appreciate that, and on behalf of the Rotary and the Planning Committee, we would like to thank you.
Thank you so much.